Ladies and gentlemen, esteemed guests and fellow participants, a warm welcome to this special online event. My name is Samantha Cord, I'm a journalist, and I have the honor of moderating today's discussion. This week, we celebrate the Spring European Testing Week, an initiative that aims to raise awareness and improve access to testing for HIV, viral hepatitis, and STIs. Together with ECDC and the European Testing Week organizers, we gather here to mark this significant occasion. Our event title is HIV, Hepatitis B and C, and Sexually Transmitted Infections. Why is testing important, and what can be done to increase testing, access, and uptake? Throughout this session, we have an exceptional lineup of presentations and discussions prepared for all of you. And please note that the presentations will be recorded and made available on the ECDC YouTube and European Testing Week YouTube channels and websites. So you will have the opportunity to revisit any part of today's events or catch up on what you might have missed. And I'm delighted to witness such a strong turnout today, with so many of you committed to advancing the conversation around testing. To actively engage in the dialogue, please feel free to ask questions in the Q&A block on the platform's right side. You can choose to have your name visible or ask anonymously. Additionally, I encourage you to utilize the chat function to interact with fellow participants throughout the event. This is a fantastic opportunity to share experiences and insights, fostering a collaborative environment. Let's extend our reach beyond this virtual space and continue the conversation on social media using the hashtag EuroTestWeek. By doing so, we can amplify today's discussions and involve a wider audience in our shared mission. Now, without further delay, I have the great pleasure of introducing our esteemed guest, Andrea Amann, the Director of ECDC. Her expertise and leadership have been instrumental in shaping the agenda for public health initiatives. Please join me in giving a warm welcome to Andrea Amann.
Thank you so much, Samantha, for the nice introduction, and a good afternoon to all of you who are joining us. Thank you for doing so. As Samantha said, we are marking the Spring European Testing Week 2023. And I'm really happy to see representatives from different organizations that are working towards the same goal, highlighting the importance of testing and increasing testing access and uptake. Reaching and testing those at risk of infection with HIV, hepatitis B or C, and sexually transmitted infections is still a challenge in Europe. And the European Testing Week is a key opportunity to increase the awareness about the benefit of testing for these infections. It is also an opportunity for everyone in Europe to become knowledgeable about the risks posed by these infections and the importance of knowing one's status. Testing and early diagnosis allow access to life-saving treatments and helps prevent further transmission. This is one of the key messages that we want to get across. When we look at HIV, it continues to affect the health and well-being of millions of people in Europe. Over the course of the last decades, nearly 590,000 people in the EU-EEA and over 2.3 million in the wider European region have been diagnosed with HIV. About 1 in 8 or 12% of people living with HIV in the EU are unaware of their status, which means that looking at the goal 25, having 95% of people living with HIV diagnosed, we're still ways to go. On average, people live 3 years with HIV before being diagnosed. And late diagnosis delays the access to treatment and increases the risk of health complications and reduces the quality of life. Turning to hepatitis B and C, it is estimated that in the European Union, and the European Economic Area, there are approximately 3.6 million people living with chronic hepatitis B infection and 1.8 million people with chronic hepatitis C infection. However, available evidence suggests that there has been a steady decline of reported number of new transmissions of hepatitis B in all countries related to the effective implementation of hepatitis B vaccination. And that is a very good development. For hepatitis C, countries in the region have reported a decline in the number of new transmissions as well over time due to the impact of primary prevention measures. But this is not the case for some key populations, such as people who inject drugs, who are disproportionately affected by hepatitis C and who often face barriers and gaps in services that need to be addressed. Available data suggests that a large proportion of people living with hepatitis B or C remain undiagnosed. Concerningly, there is evidence that some are diagnosed too late and already in the stage of having a cirrhosis or hepatocellular carcinoma at the time of their diagnosis. All this shows that work is still to be done to reach the global goals to eliminate HIV and viral hepatitis by 2030 and to reduce the health impact of STIs. So I will give you now a few examples of what we know could be improved. While HIV and hepatitis testing is available in many settings and using a variety of approaches, including point-of-care testing, integrated testing, indicator condition testing for HIV, and so forth, we need to further scale up the effective approaches to testing in the key locations and populations that are most at risk for these infections. Together with much more HIV testing, it is important to increase pre-exposure prophylaxis and rapid linkage to HIV treatment after the diagnosis. Remember that the rapid linkage to care after the diagnosis and effective treatment suppresses the virus and eliminates the risk of HIV transmission from well-treated individuals to their sexual partners. Early diagnosis, linkage to care, and effective treatment for hepatitis B and C reduces the risk of an individual developing cirrhosis or liver cancer and can also lead to reduced risk of onward transmission to others. So these infections affect many, but there are now effective ways to address them and reduce the health impact. Today, you will hear from leading experts about the current situation, the existing gaps in testing, prevention and treatment, the role of stigma that we still have, the impact of the COVID-19 pandemic on testing practices, and much more. I hope we all leave this event thinking about what we can do as individuals or as professionals to help prevent and control HIV, hepatitis B and C, and STIs. We all have a role to play. I wish you a very successful event and good discussions. Thank you so much for participating. Over to the moderator. Thank you.
Thank you, Andrea, for setting the tone for this important event and for your continuous dedication to public health. Now it's my great pleasure to introduce our first speaker, Jens Lundgren, MD, Doctor of Medical Science, Professor at Rikshospitalet and Director for the Center of Excellence for Health, Immunity and Infections at the University of Copenhagen. With his extensive knowledge and experience, Jens will shed light on the importance of testing for HIV, viral hepatitis, and STIs, as well as provide us with an insight into the current status of testing in Europe and Central Asia. Please join me in warmly welcoming Jens Lundgren.
Wonderful. Samantha, thank you very much. And hi, everybody. I hope you're well. I cannot see you, but I understand a lot of people is attending this webinar, which is great. Good to see that there's strong support for the European Testing Week initiative here. And my role is really to give you a very brief summary of where we are and what are the evidence that supports further strengthening, really as a follow-up to what Andrea correctly mentioned in her introduction remarks. Next slide, please. Next slide. One thing that I wanted to bring your attention to is that the START study that defined when we should initiate treatment, the early results from that trial was publicized in 2015 and demonstrated that people who started the treatment early, their chance of having a healthy life was substantially lower than those who were experimentally chosen to delay initiation of treatment, a topic which obviously at the time was still disputed. So, and as a consequence of START and other studies, globally, the treatment guidelines were changed to everybody starting on treatment. We have now had the chance of follow this cohort of patients after 2015 as people were starting to get on treatment also among those who were originally randomized to deferral of treatment. Next slide, please. Importantly, if you look at the situation in terms of the CD4 count, with obviously the central biomarker that HIV is affecting, not surprising in the early phase of the study before 2016, there was a large spread in favor of those who started treatment immediately, as that obviously is protecting immune function. And you saw a difference in the deferred arm as people gradually started on treatment. Importantly, after 2016, as you can see on the right, although the CD4 trajectory is on a positive slope also in the deferred arm, it never really reaches, despite 6 years of follow-up, those that was obtained by those who initially started treatment early. Really underlining that immune repairment takes time to happen. And obviously, the way to avoid that is to get people on treatment earlier. Next slide, please. Also, when you look at clinical diseases in follow-up, although the difference in risk that favored the immediate arm was obviously striking before 2016, if you look for the primary outcome of AIDS, serious non-AIDS, and death. And although those differences were less marked after 2016, there actually is a residual excess risk. And certainly, if you look at the entire 10-year course of the study, those who started treatment earlier, they had around 40% reduced risk compared to those who have started treatment more delayed, with a CD4 cell count around 400. So obviously, these numbers would have been much more extreme if the deferral strategy was, say, 200 or 100. So it really provides you with quantifiable experimental evidence that for people's own health, it really matters if they are diagnosed early and placed on treatment. Next slide, please. The other obvious benefit from getting people on treatment is the fact, as we and others have shown over the years, that among those people who is on treatment, which is suppressive, their ability to transmit HIV to others becomes negligible, which is the whole foundation for the U equals U global campaign that I'm sure many of you is aware of, and which still holds true. So you have a benefit to yourself, and you have a benefit in terms of not infecting people in your social network, sexual partners, etc. Next slide, please. Now, so how many people is actually left with detectable, or you can say undetectable virus, so they are on suppressive treatment. And clearly, we are not at goal yet. In the Western region, around a little over 20% remains biologically detectable. It's over 50% in the central region, and at least by these estimates, somewhere in around the 45% in the eastern region. So there's a lot of people still out there that for various reasons are still able to transmit the virus. Next slide, please. So, so these are the numbers in crude numbers by the best estimates from the ECDC. So over 800,000 people across the continent are in this situation, either because they are undiagnosed, they are diagnosed, but for some reason it's not linked to care, or that they are on treatment but not fully suppressed. So there's a lot of things to be said around this slide. Obviously, we're discussing here testing, but testing in isolation really doesn't make sense. It's testing in the context of making sure that people who are diagnosed positive, that they are seamlessly transitioned into appropriate and comprehensive care to get them on treatment because it benefits themselves and their social network as shown. And as a consequence, we will also hopefully start to see a lowering of this pretty striking number that was from this estimate. Next slide, please. Late diagnosis is obviously the opposite of this, where people are diagnosed fairly late in the course of their disease. And that number we have wanted to obviously get to as close to zero. The more comprehensive your testing strategy is, the lower that number will be, but still it remains around 50% across the region as such, more so in older people and more so in those who is infected heterosexually than men who have sex with men. So it's not optimal, but at the same time, as you can see on this slide, it is very similar depending on geographical region. Next slide, please. Importantly, there was recently an effort to update the original consensus of how we actually define late presentation, as there were some pitfalls in that definition that needed to be repaired. And I just wanted to acknowledge the more recent publication that was endorsed by the EACS and ECDC and WHO regional office, and which was discussed at a webinar in November last year. So it's important, and we discussed late presentation, that we're using the same definition, and I encourage people to use this one that you can see on the far right there. Next slide, please. Mild hepatitis, I don't think I can add a lot to what Andrea was saying already. It's sizable numbers of people. Few of them are diagnosed, and even few of them are treated. So there's a lot of unmet need, you can say, in making sure that we are comprehensively tackling those sections of the population that is infected with those two viral hepatitis causes. Next slide, please. And again, when we talk about sexually transmitted infections, I mean, they in numbers are superseding to some extent the other diseases, maybe not as harmful to health, but nevertheless have an impact on people's health, reproductive ability, etc. And you can see here for the estimates for syphilis, gonorrhea, and chlamydia overall in the adult population in Europe, 0.11%, 0.3%, and 2.7%. So a sizable number, and obviously testing is a central part of dealing with them. Next slide, please. Now, how should we think about building an evidence-based testing strategy? I think the good thing is that we, meaning a lot of the international organizations, ECDC, WHO, supported by academics in many countries, have over the years developed fairly sophisticated testing guidelines that are built in a way that they are implementable. Obviously want to make sure they are integrated. So who to test. It needs to be risk-based, it needs to be broad, and it needs to be clinically approached. And I don't want to spend time going into details of this, but I think in terms of if you want to build in each member state or country in Europe wants to build an evidence-based guideline testing initiative, there's very good documents to build those efforts on. Next slide, please. We realize that there's a number of testing barriers. There was recent meetings that outlines the structural barriers and the implementation gaps. Again, I don't have time to go through them in detail, but I think it's important that these structural barriers are multifaceted and involve both political issues, but also to some extent thinking about diseases in silo, as opposed to have a more comprehensive approach to how we test for infectious diseases, legal barriers. And another thing, just to come to that, next slide, please. Just want to recognize that HIV and to some extent also viral hepatitis is still associated with stigma that is counterproductive for a comprehensive testing strategy, and therefore this issue needs to be dealt with as part of any national rollout of a comprehensive testing strategy. Next slide, please. Importantly, there's been studies done as well in terms of addressing questions. Do national testing guidelines include recommendations for integrated testing for HIV, viral hepatitis, and sexually transmitted diseases? And you can see here on the middle bar, only 30% of national testing guidelines do indeed do that, but 47% do not. So there's still a lot of work to be done in countries to try to streamline their testing strategies according to international recommendations. Next slide. Another example, just to hit on a point, a lot of people who is HIV positive, in particular those whose late presenters, are actually seen in the health system before they get diagnosed. And each of those visits you can consider is a missed opportunity. So how well are non-HIV specialties that typically see those patients, how well are they adapted to make sure that they do an appropriate HIV test in case of certain indicated conditions? And it's not good, actually. This paper in Neurosurveillance gives details on that across the continent. So there's still a lot of work also within the medical specialties to adapt their guidelines so they become comprehensive and according to international recommendations. Next slide, please. Just a brief note here to emphasize this point from a Danish study looking at people who was late presenters and compared to matched controls in terms of how frequently they were seen 3 years prior to being diagnosed at late presenters. And the observation clearly was that over 90% were actually seen, had at least one visit in the preceding 3 years. And if an HIV diagnosis has been made, those people would have a chance to get on treatment before they further progressed with all the negative consequences that I discussed earlier. Next slide, please. So in summary, we must address the testing gaps. 1 in 5 people living with HIV in Europe are unaware of the HIV status. Half are diagnosed late. Undiagnosed poses challenges to their own health and to those close to them. Similar, if not worse, for viral hepatitis and STD. We know that there's evidence-based guidelines. They exist, but not readily and truly comprehensively implemented across the continent. Hence, focus should be to adapt into national and specialty guidelines, those guidelines, in my opinion, humble opinion. We need to understand the barriers for not implementing the guidelines, express some of them. Concerns remain for stigmatization, requires continued political support, be rational in that insistency, support surveillance efforts. We need to have data to convince politicians that this is actually need, so we can have a data-driven testing strategy, and continue to think outside of the box. We are not here to resolve one infection. We are here to improve public health across a number of different disease areas. So we need to really broaden our scope to think broadly around that. So key points: scale up prevention, provide ART to all, and address stigma would be my conclusion. And next slide, just to I want to compliment and acknowledge a lot of people who has helped me to put these slides together. People at CHIP here in Copenhagen, Dorte, Anne and Maria, and others, colleagues at the ECDC, in particular Timor and Anastasia, and also Raquel that provided some information as well. Thank you, Samantha, over to you.
Thank you so much for this insightful presentation, Jens. You really highlighted the importance of testing for HIV and viral hepatitis and STIs. Just to let you know that this event is being recorded, so if you didn't get any sound, or it will be recorded, so you have time to go and revisit the presentations that you might have missed. We do have time for one question, because I know you're pressed for time. In your presentation, we heard you talking about how you think the undetectable equals untransmittable agenda changed the perception of testing. Do you have any ideas for normalizing testing in the healthcare test?
Well, I mean, it's really two topics here that you're addressing. I mean, I think it's quite obvious that if you are HIV positive, you want to be in a situation where you're not able to transmit to people that you're around in your social network, your sexual partners, and the U equals U campaign built on evidence, I think was helpful in appreciating that goal can actually be achieved. And therefore, it should further endorse an interest by people who is potentially exposed to HIV to get an HIV test in case they're infected, so they can get on treatment and not further forward transmit the virus. So I think that is helpful, and I think it's just important to remind each other about that campaign is not a campaign based on rhetoric. It's based on solid evidence. And there was a strong collaboration between those who was driving the campaign globally and those of us who were part of generating the evidence. And we still therefore support that campaign also from the academic and research side. I just wanted to emphasize that. The other topic you're mentioning, I'll address quite briefly, namely that this is really the question about whether the health system in totality should be part of testing efforts for transmissible diseases of the type we're talking about today. And I think the resounding answer to that is yes. Because that's what health system is supposed to be doing. That is to help to improve public health, and obviously that was what the health system did also during the pandemic. So those lessons learned needs to be transitioned into our discussion about making sure that the totality of the health system are engaged in testing for the diseases we're talking about here. And I want to just make sure that we are reaching out to colleagues in other specialties. I'm an infectious disease doc, so I can convince my colleagues in my department that's not a problem. But I want to make sure that the general practitioners, people in other specialties, they feel equally comfortable ordering an HIV test where it is indicated. We have good guidance for when that is reasonable to do, but we want to make sure it's implemented in guidelines that they are following in those clinics, and we want to see that happen throughout the continent. I think that's the real point that we should push on everybody. Thank you.
Thank you so much, Jens, for a very, very insightful presentation, and good luck with your great work. Thank you. Ladies and gentlemen, our next topic explores who should get tested, when and how. Our presenter is Anastasia Faris, ECDC Principal Expert Infectious Diseases and Group Leader for STI, bloodborne viruses and TB. She will provide insights into the ECDC guidance on testing, including various testing approaches, such as self-testing sampling, rapid test, GP testing, testing in pharmacies, and routine opt-out screening and low threshold testing facilities. Please welcome Anastasia Paris to share her expertise on this very important subject.
Thanks very much, Samantha, and thanks to the European Testing Week organizers who are spearheading this great initiative again this year. I'll focus a bit on the topic that here, who should get tested when and how, and there's a lot, but we'll come back to this in the next few presentations in terms of the specifics and some examples in terms of implementation. Next slide, please. So the framework for all of this is the Sustainable Development Goal 3, and that is about improving healthy lives and ending AIDS and combating hepatitis by 2030. And so this is a framework under which we are performing testing. Next slide. Jens presented to us the numbers. This is for the EU, but we still have millions of people who are living with HIV or hepatitis B or C, and a lot of those people are undiagnosed, particularly in the area of hepatitis. But this is a problem throughout the EU that too many people remain undiagnosed. Next slide. Also, we're not talking so much about STI today, but we do have increasing rates of STI. This is data on syphilis, and it is increasing over the last decade. We see similar trends for gonorrhea, and this is particularly in the population of men who have sex with men, who we know test more often. But this is something that Testing Week is also starting to focus on more, and which we applaud. Next slide. But back to HIV and hepatitis, a lot of late diagnosis, and this results in poor health outcomes for the individual. It also results in healthcare costs for society, as well as more transmission. And testing is both an entry point to treatment, a really important one, because and treatment for HIV and hepatitis B and C can eliminate or suppress the viruses and improve people's health and reduce transmission. Also be an entry point into prevention. And so those tested negative can then be referred to services that they need, such as pre-exposure prophylaxis for HIV, harm reduction, vaccination. And it can also be an important prevention for those who are tested positive as well, in terms of notifying their partners and being aware. Next slide. There's a lot of testing guidance out there. The WHO has done really, really good work in this area. At ECDC, we've tried to take this and make it relevant to European settings. And we do have specific guidance which look at populations such as men who have sex with men, people who inject drugs, specific issues on models of care for testing. Next slide. Today, there's also really important clinical guidance from the clinical societies, and many of you have national guidelines that you're also implementing nationally. So there's a lot out there, but we've tried to bring this together in the next slide in work that we did with a variety of partners. Next slide, please. To look at a setting-based approach to integrated HIV and hepatitis testing. So this was a collaborative approach which we performed at ECDC and published in 2018. It's meant to complement the existing guidance out there and take an approach to where can testing happen in an integrated way for HIV, hepatitis B and C, and how can this happen in different settings, given the variety of epidemics that we see and differences in epidemiology across our region. We do know that it makes sense to have an integrated approach because there's common modes of transmission for these infections, there's an overlap in the risk groups, and there's also synergy at service provider level to provide this patient-centered approach to testing for all viruses where applicable. It's based on systematic review and expert opinion and covers these topics of where, who, and how to test. Next slide. So in the guidance, we have some core principles. I won't get into the details, but it's important that testing be normalized, that linkage to care be in place, and that this should really be accessible, voluntary, confidential, and based on informed consent. Next slide. There's across the European Union where we work at ECDC, there's a really big difference in terms of the populations that are most affected. And this looks different both at national level across our region, but also within countries. And so there's no one size fits all approach, but there are some populations that consistently across the infections do tend to have higher prevalence of infection. Next slide. So what we need to do is have a local knowledge of epidemiology, and this is why surveillance and monitoring is so important at local level. And we need to take that local knowledge to look at the populations that are most impacted by HIV and or hepatitis B and C, and then adapt what is to your local setting. Next slide. And so Jens quickly touched on this, but we can have a risk-based approach where you look at populations that identify themselves as a member of a risk population. And some of the populations are listed here where we've seen that there is higher prevalence of one or several of the infections. There are also broader strategies, such as testing of an entire birth cohort. This has been applied in particular for hepatitis C, where people who are born in a certain age, span of years are tested, where it's found to be cost effective, or areas where there's a high or intermediate prevalence of one or several of the infections, where everyone who attends a GP clinic is offered testing. Also, antenatal screening is a broad strategy that's applied throughout Europe. And then there's a clinical indicator testing approaches, such as HIV indicator condition testing, which we'll come back to a bit later, or testing of people who have symptoms or biomarkers. And then we really, really stress that anyone who's diagnosed with any of the infections should be tested for the other two. Next slide. The frequency of testing is also going to be based on individual risk assessment and local epidemiology, but broad guidelines that were put forth by our expert panel were that it made sense to test these certain populations every 6 to 12 months, retest depending on ongoing risk and vaccine status for hepatitis B. There are other populations where at least once lifetime testing makes sense, and then ongoing risk will determine whether retesting should occur. Next slide. Where to test? There are a variety of settings. There's never been testing offered in so many places as there are today. There's been really huge advances in this in Europe. So obviously primary care and hospital settings, but also in antenatal screening clinics, STI clinics, pharmacies, prisons, drug services. We see really interesting and exciting examples of testing programs. And community settings, this is something that Europe is leading the way globally in terms of the community-based organizations that are implementing testing in our region. And then also approaches to self-sampling and self-testing in a home-based manner. And then finally, this geographically targeted routine testing, which I mentioned earlier. Next slide. In primary healthcare settings, it's important that testing be offered in an integrated way to anyone who self-identifies as a member of the risk groups I mentioned previously. Anyone who is presenting with clinical symptoms should be offered the test for the 3 infections, and anyone with laboratory markers compatible with hepatitis or an HIV indicator condition, including an STI, should be offered testing. We also suggest that if, as mentioned, if anyone's diagnosed with one of the 3 infections, test for the other 2 and consider testing for STI. Routine testing in emergency departments is also something that's been applied and very successful in some countries in Europe recently. Next slide. In community settings, it's really important that there be pathways in place to ensure that confirmatory testing can occur if it's not happening in the community setting, and that linkage to care is ensured. But we have seen time and time again over the past decade and beyond that testing services by lay providers work really well, and they can increase testing opportunities, uptake, and coverage of testing for HIV, hepatitis B, and C. Next slide. We have seen, this is sort of a busy slide, but an important one. This looks at which countries in Europe have different modalities of testing that they're implementing. This doesn't mean it's available to everyone across the country, but it's in place in the countries in the EU and Central Asia. And what we see is that a lot of countries do have community testing or provider-initiated testing, antenatal screening, but fewer have those which are listed at the bottom of the slide, self-testing, lay provider testing, home testing available. What we have seen, interestingly, is that self-testing has increased quite a lot between 2018 and 2022, and this is probably a side effect of the experience that many of us had self-testing for COVID-19 and policy changes as a result of that, which may be impacting our area positively. Next slide. So finally, it's really, really important to plan and deliver the services to enable people to be able to get testing as we're recommending. People do want to test, we find, when they're invited to do it in a way that is convenient for them and which is non-stigmatizing and user-friendly. And so increasing both the convenience and supply side through flexible modes of approach to testing, rapid diagnostics, point of care testing, reflex testing for hepatitis C, but also increasing demand. So automatic pop-ups to ensure that clinicians remember to offer these things, because clinicians want to, but sometimes in the busyness of their schedules, it gets missed. having messages of test often for those who are at highest risk, so that it's something that is a reminder service, maybe offered by SMS, and then co-locating services with the provision of other things that people need, such as PrEP, treatment, or STI screening, for example. Next slide. And so in summary, there's a lot of value to be gained by integrated testing for HIV, STI, and viral hepatitis. They share common modes of transmission, and they're often impacting the same populations. So this makes sense. It's the only entry point that we have to effective treatment, and there is effective treatment available in Europe today. But this is key, that testing is the starting point. It's also key to prevention and reduced transmission. And so increasing a variety of effective testing options available is crucial, and European Testing Week is a part of this initiative. We need to tailor the options that are available to the local context and share experiences in platforms such as we have here today and beyond as to what's working, what's successful, and how we can learn from each other. So with that, on the next slide, I'd like to thank the European Testing Week organizers, but also my colleagues at ECDC and collaborators that we have at WHO, UNAIDS, and our many, many colleagues in the member states that we collaborate with on HIV and hepatitis. Thank you.
Thank you so much for Anastasia for sharing your valuable insights. Later on, you will be have a Q&A after the next speaker. But before that, I just have one quick question. You presented several options for testing approaches, but what's the best approach for European countries to implement, would you say?
That is, there's no answer to that one, Samantha. There is no one best approach. And that's, I think if there were, it would probably be easier. But because the epidemiology and the health systems that we have differ so much, we have to tailor the approach. And even at country level, it's probably not possible to have a one-size-fits-all approach. But we need to look at who are the people that are impacted by the infection in a given country, and where will they access services, and tailor those to the needs that we have. But what we can tell is that due to so much late diagnosis that we see, we're not there. We're not succeeding. And probably no country in Europe is really there yet. So we have some ways to go in order to implement our services in a way that is more impactful.
Thank you, Anastasia. Please stay, because we'll have a Q&A later on, and I encourage all of you in the audience to submit your questions for the later Q&A. But for now, we'll shift our attention to the topic of reaching those at risk with testing services, including the impact of COVID-19 and the war in Ukraine. Our next speaker is Magdalena Ankerstein-Barczak, a member of the European Testing Week Working Group and CEO of the Foundation for Social Education in Poland. She'll provide a community perspective on testing, emphasizing the importance of community testing in reaching key populations and sharing examples of reaching different at-risk groups. Additionally, Magdalena will share her experiences with COVID-19's impact on testing services and ensuring access to testing for Ukrainian refugees in Poland. Please welcome Magdalena Ankerstein-Barczak.
Thank you very much for giving me this opportunity to present our foundation experience from the last few years. As you mentioned, I'm CEO from Foundation for Social Education, working in Warsaw in Poland, but I'm also EATG member and also EACS member. Very quick overview about HIV in Poland. You have to know that only 10% of adult people in Poland had ever tested in their life. It's a very low rate. For the second part, only 87% of Polish people thinking that HIV is not their problem. So we have also lack of knowledge about risky situation in general population. And from the research, we know that 44% of newly diagnosed patients in Poland continue to present late or AIDS stage. So we have very huge number of late presenters, and it's also because people are not testing. As you can see, we had the situation of the COVID-19 where the number of tests and number of diagnosed people were going down. But also in the last year, we have almost double number of newly diagnosed people in Poland. So it's also a scary situation when we are knowing that not enough is doing for the key population, and also still half of newly diagnosed are late presenters. Professor Roszczynska made a simulation with ECDC that we still do not know the real situation of the in Poland around HIV. This is also the situation about STIs that, as you can see in the last few years, especially in the last year data showing that we have a huge increase of number of people who get positive result of other STIs. And also, when you are concentrate on the testing, you have to know that on the primary healthcare system, we cannot do HIV test, we cannot do hepatitis B test. Only last year we implement hepatitis C on primary settings. And there is not so often testing in hospital settings. We have only few STI clinics, so there is also problem where to go if you have any STI symptoms. And harm reduction programs and services are hosted and organized by NGOs, and NGOs are based on the funding that they organize by self, not from the governmental level directly. So also we have very huge barrier of testing because people under 18 years old cannot be tested without permission of family, of their parents. Also, we do not have self-sampling. We implement as an NGO self-testing piloting project. I will mention about it more lately, but still it's not a general possibility to get self-testing in Poland. You can buy it online, but it's around 25 euro. This is some data from our Foundation for Social Education. We opened our first VCT center in 2003, so it's 20 years right now. In 2017, we opened the mobile harm reduction service. It's only one harm reduction service in Poland, so it's a camper that you are going to drug users and testing them, and also have a needle exchange program in Warsaw. In 2018, we opened integrated testing in our VCT center, so we compare HIV, hepatitis C, and syphilis testing. And as you know, also as a SARS-CoV-2 to implement a huge barriers of testing. So during the COVID situation, we implement first piloting project of self-testing when we had in Poland first lockdown. In 2022, of course, everybody knows that situation in our eastern part of Europe was changed, and war in Ukraine also changed the situation in Poland. So first of all, about COVID-19 impact for the situation in Poland. This is data showing from the National Institute of Public Health, showing that the biggest number going down of testing was in VCT center. We didn't see in general population the decrease of testing. It was very, very small, but as you know, we have also very small number of people who are testing in general population. And this is also very important to mention that, especially in key population, this is the number of testing rate was not enough, and COVID limited the possibility to test, especially during the lockdowns. As you can see in our data from our 2 VCT center in Warsaw, we have also in 2020 much lower number of people who are coming for testing. Right now it's going up, but it's not still the same before the COVID. So as I mentioned, we implement piloting project for self-testing in Poland, so people can order by helpline these tests. And it was a huge success because 66% of people who ordered this test had never the test before. The impact of war in Ukraine in Poland is obvious, and everybody know about it. But it was also, we have to keep still in mind that we do not have only Ukrainian migrants. We have also huge crisis on Belarusian board. And this is also have a huge impact in from our foundation work. We had some funding, but all of funding were finished already in February 2023. So we doing right now everything as a volunteer. So we implement all our services, transfer and implement information in Ukrainian and Russian language, and also right now in English language. So we didn't see as big impact of people from Ukraine who are coming for our VCT center. As you can see, only 200 people came to the VCT center. And much bigger impact were in mobile harm reduction service. And this is what I mentioned about other migrants that we see not on Ukrainian people, but also other countries like Georgia, Armenia, Chechnya, and other countries in our mobile harm reduction service. And the barrier is that those people very often do not want to get tested, even though that it's anonymous and free of charge. So we have also implementing a second part of the project with self-testing with other organizations from Wrocław and funding from European sponsors. And it helps help also implement testing for other people, especially from Ukraine. So as you can see, this is what I present in Poland. We need especially long-term strategy of self-testing because all projects right now are finished. We need to have an access for STI testing in medical care setting and also STI clinic to have open possibility to testing. We need a target intervention among key population because still MSM population, LGBT community has a huge problem to go to the different service, and also we do not have dedicated campaign for them, and we have new challenges. We need new funds and we need new possibilities to go through another problems that are around us. And of course, I would like to introduce all of you for EACS conference in Warsaw that I have honor to be a co-chair as a local community, and hope to see you all in Warsaw. Thank you very much for your attention.
Thank you so much, Magdalena, and such an insightful presentation, both hopeful and insightful, of course. Your expertise and perspectives had shed light on crucial aspects of testing for HIV. So now it's time to move on to the Q&A session, where we'll address you, the audience question. But I would like to start with a question of my own, and this goes for you, Magdalena. Have you seen an impact in testing after COVID in Poland? Can you hear me?
Yes, I see. I hear you. Thank you. Thank you for your question. After COVID, we see that people start coming more right now. We have much more numbers of people who are coming for testing, but it's still, we don't have such a big number that it was before COVID. So we right now preparing as a foundation campaign about testing, showing that this possibility are still possible, and we still would like to share the knowledge that testing it's the very important thing.
And can you elaborate a bit about which testing service are the most used by the Ukrainian migrants you mentioned in your presentation?
We started open VCT centers for Ukrainian people, so we have also counselors speaking in Ukrainian and Russian language. But from other side, we see also that the self-testing it's a best option for those people because they have openly can do this test by themselves. And especially it's important in smaller town and smaller village that you can do the test at home. But right now we don't have any funding for that, and we have to find a possibility and solution to do it.
Mm. And also, another thing you mentioned in your presentation is that you would like the testing to increase by far. So what should you do in Poland to have more people get tested?
As a foundation, we try to organize funding for a new campaign promoting testing, but also from other side, we see a huge need to talk about HIV because HIV it's not a topic in public space, and we have also right now a huge problem to have sexual education at schools. So and also what I mentioned about LGBT community, it's hard to dedicate program for them because of many political reasons. So this is a lot of problems that we are right now faced on it. And the main one is the funding, especially from public donors, to find the possibility to implement the projects.
Okay, thank you so much. We have a question for Anastasia. Are you with us, Anastasia? Are you still there?
Yeah, I'm here.
You. And this question is from Anna Maria Gueretti. Anna Maria agrees with the principle of integrated testing for HIV and hepatitis B and C as much as possible. The approach may have to be adapted to different settings, though there is evidence that the concomitant offer of an HIV test reduces uptake of hepatitis C testing in some settings. Do you have data on this aspect?
We don't have data on that specific issue, Anna Maria, but thank you for your question. And I think it does go back to this issue of, this is a broad principle and something we have seen works in many settings, but there is no one size fits all. And so it is important to, engage in listening to the people that you're testing, dialogue, with community partners like Magdalena's organization, to see what, if something is a barrier and is causing people not to accept the testing, then yes, absolutely adapt, or maybe think about the messaging, or whether, sometimes just not making it a big exceptional thing, but just saying, this is what we do. Let us know if you're not okay with that. Usually does work, but there may be certain populations or settings where, for different reasons, that's not acceptable. And then maybe there's a need to work on stigma and education on those topics with the healthcare providers and patients and community.
Thank you. We have another question for you, Stacia. This is an anonymous person asking, can ECDC elaborate on stigma and discrimination affecting testing? And I'm sure you can answer that as well after Magdalena. But please go ahead, you first, Stacia.
Yeah, we know it impacts stigma and discrimination impact testing a lot. We have information from a very large internet survey that was done of gay, lesbian, and bisexual, transgender Europeans about 10 years ago now. It's just been repeated again, but indicating that in many countries, more than 60% of people had never disclosed their sexual orientation, for example, to any healthcare provider. And so in such a situation, someone is not going to actually have an open dialogue about, potential risk or need for testing, or the provider may not ask. And so these are really, really important fundamental factors that are going to impact testing. So we know that this is of an important issue. It's something that the Spanish presidency of the EU is taking leadership on, and we're really happy for that. And there will be a high-level meeting to discuss this in September of this year. And ECDC is looking at how we can support the measurement around stigma and working together with community partners and clinical partners to impact on sort of trying to address then what we find once we measure.
Thank you. Would you like to add something to this, Magdalena? Because I'm sure that...
Yeah, stigma. It's one of the biggest barrier when you have a fear of thinking about HIV. You will never go for testing. So this is something that we have to keep in mind also, and implement program and campaign anti-stigmatization, especially in homophobic countries, and especially right now with a lot of migrants, to open the door for them and inviting them for testing.
Thank you so much. Some things yes, thank you. Thank you. We don't have any more time for this wonderful Q&A, but I encourage the audience to please keep on submitting your questions. And it's time. I thank both of you, both Anastasia and Magdalena, for your excellent presentations. And they really gave us great insight and in look into how you both work. Thank you so much.
Thank you.
So it's time for us to move on. And it's time to delve into the topic of increasing access to and uptake of testing for HIV, hepatitis B and C, and STIs. We have the privilege of hearing from two experts matter. Our first speaker is Daniel Simos. He's co-chair of Eurotest and a member of the European Testing Week working group. He'll shed light on the contributions of European Testing Week, enhancing access and uptake of testing for HIV, viral hepatitis, and STIs. And furthermore, Daniel will address the needs of the general public, emphasizing the importance of easy to understand information, increased knowledge and awareness. And our second speaker directly after Daniel is Anne Sullivan. She'll focus on the role of policymakers and healthcare practitioners in increasing testing access and uptake. She'll discuss the significance of keeping these infections on the political agenda, ensuring funding for interventions and information campaigns, removing legal and policy barriers, and advocating for new and innovative testing practices. Let's welcome Daniel Simos, and after that, Anne Sullivan, as they share their valuable insights on what is needed to enhance access and uptake of testing. And please, to the audience, please submit your questions for the upcoming Q&A. Welcome, Daniel.
Thank you. Hello, everyone. Let me start by thanking the invitation. So, as was mentioned, I'll be splitting the floor with Anne. Always a pleasure. I'll be focusing on more of the non-clinical settings, and Anne will be focusing more on the clinical settings, also related to our expertise. Next slide, please. So, can I have the next slide? Thank you. So just as a form of introduction, you've seen the data, so you know already that there's still a lot of work to do. As Magda very well illustrated, we in many countries have not recovered still from the disruptions caused by COVID-19. And as was very well shown in the previous presentations, all these infections remain concentrated in key populations. And so there are groups that are of higher priority in terms of interventions. Additionally, we have still a lot of gaps in our understanding of epidemiology for these infections in different contexts. Some contexts are a bit better, some contexts not so well. And particularly for STIs and viral hepatitis, there are many gaps in terms of the available information and our in-depth understanding of these epidemics, which makes it harder to tailor testing interventions to our contexts. However, there is a lot of low-hanging fruit in terms of, for example, integrating testing offer, where there's still a lot to be done. Next slide, please. So we're on a timer for the international agreed goals and for the SDGs. We have 7 years, so it's still a long road, but it's very possible to get there in a vast majority of contexts if there is real will and adequate investment. However, contexts are very, very heterogeneous, as we've seen. There are different prevalences and epidemiological contexts in Europe. So what can we actually do? Next slide, please. At a policy level to start with, which is an absolutely crucial level to ensure that we increase access and uptake of testing, there is an urgent need to have HIV, viral hepatitis, and sexually transmitted infections on the political agenda at a national level. So the SDGs are very wide. There is one SDG for health, which touches upon many health issues. There is one specific point on these infections, and we need to push for that point to be a priority at the political agenda. Alongside investment, it is not enough to have the words there. We need to have the funding to back up these words. Additionally, we will need information campaigns and locally adjusted testing programs, which need to come from that investment. Political priority also means that there needs to be a push to removing some of the critical barriers that still remain. Criminalization of several of the populations that are most affected by these epidemics is one of the key barriers. Stigma and discrimination remain, as was just mentioned, also very important barriers for testing and the rest of the continuum of care for these infections. There are others, as written consent for testing, for example, age of consent, as Magda mentioned, in multiple settings, as well as sometimes legal, sometimes regulatory restrictions to different testing approaches. Whether it's community testing by lay providers, self-testing, self-sampling, amongst others, are still not possible in many contexts. And I'll touch on why that's important going forward. There are also additionally, there are also issues around funding and pricing, and ensuring adequate funding of high quality testing programs adjusted to local epidemiology is the basis of, if we want to be serious about it, we really need to adequately fund good testing programs. We need to promote integration of testing as much as possible and where relevant according to local epidemiology, which also requires an investment. There is a return on that investment, but there needs to be an investment. We also need to invest in high quality data collection, so surveillance and monitoring, as was mentioned, to understand our epidemiology and so we can properly tailor responses to the needs of the people that we want to reach. And that also requires investment. We also need to push for affordable testing prices. And when I mention testing here, it's not just the testing kits, it's also everything that's associated with diagnosing and these infections and also going forward in terms of monitoring treatment, for example. And this can be done at a national level, but also can and should be done at a European level when necessary and relevant. Can I have the next slide, please? So when we're looking at this, we can look at this from two perspectives when we're talking about increasing uptake and access. One is general population, which generally is less aware and less informed about these infections. And so there's no added value for me if I don't know why I should get tested, I'll probably never look for testing myself. So we need to ensure that people know why is it good to test according to obviously their history. And not everyone needs to be tested for everything. But if I understand when I should get tested for each of these infections, the probability that I'll look for a testing response is much higher, obviously. So we need to invest in access to easy to understand information for the general public, and we need to do that regularly. We need to increase knowledge and awareness, generally speaking. So we need to invest in public communication. And we already lost an opportunity to occupy the space that COVID-19 occupied in our mainstream media with health information. And we need to take that back for other infections. One example is through European Testing Week, which is a European initiative, but has a local, national and local impact. I have the next slide, please. And that impact is very visible. So as you can see here, 34% last year of participants in European Testing Week were focusing on different infections than normal. So they increased the offer of testing, and 28% were targeting new groups. So we're reaching new people. Also, communication-wise, there was a total reach of over 246 million people. So there was a very broad reach, but this was 1 week. Now we have another week, but 2 weeks per year may not be enough to get where we want to be. Another limitation is that, as you see from the type of participants, the majority of them are from non-governmental organizations or civil society organizations, followed by healthcare facilities. So we need to invest in bringing on board the less usual stakeholders so that we have broader involvement and even greater impact. Can I have the next slide, please? So the second angle is key populations, which are where the biggest burden of infection is concentrated. And what we need to do here is to provide testing options adjusted to the needs and preferences of different people. The thing is, we need to understand what are the needs and preferences of these different people in order to provide them with adequate testing options. Generally speaking, the more options we have, the bigger our probability is of being able to actually reach people, generally speaking. But then we need to understand our epidemiology, and we need to understand what groups are we talking about. Integrated testing, as was mentioned, is one of the, I would say, one of the obvious options. And going back to the question that was asked, our experience is that when we offer voluntary integrated testing, we have very, very few refusals. So for the majority, when we are offering additional tests in a community-based setting, people in the vast majority of people tend to accept it when they understand that it's relevant for them and has a possible benefit. We need to upscale community-based testing programs, particularly for key populations, because community organizations are in the best possible place to reach the underserved populations, which tend to have less access to formal health systems in any country. Similarly, self-testing and self-sampling have a very, very big margin for improvement in Europe, generally speaking. We have to be mindful that these programs can be paid programs, but we need to have a free component, particularly for key populations, or we will be cutting off access probably of some of the people who need it the most. And we need to create enabling environments, whatever the setting that we are providing testing is, in order to ensure that people feel welcome, they don't feel judged, and they're not afraid to go to prison for asking a test or to be deported, which is still a problem in many countries. We also need to facilitate access. So we need adequate schedules, adequate location. We need to have people from the different groups that we want to work with involved in planning and delivering the responses in order to obviously facilitate access and improve the quality of the services. Next slide, please. And in sum, that's it. I'll pass it on to Anne, which will carry on with the health settings. Thank you.
Thank you so much, Daniel. So over the next few minutes, I've been asked to describe how or ways that we could potentially increase access to an uptake of testing for HIV, hepatitis B and C, and STIs, and give a few examples. So next slide, please. So in the simplest of terms, how we could increase testing would be increasing where we can test. And this is focusing primarily on healthcare settings. So Anastasia has already mentioned that this has expanded, but probably not to the extent that we really need it to if we're going to get adequate coverage of offer of an HIV test and then integrate that testing where applicable. And it's also important to think that this needs to be equitable, the access to the testing. The ways we can increase uptake of when a person is being offered a test is by how the test is offered. So there are some general principles around how a test might be offered. We should also be normalising testing, and we need to integrate testing where it's indicated. Next slide, please. So these general principles really apply to all tests, that they're specifically particularly important in regards to HIV and also hepatitis, that a test should always be voluntary, it should be confidential, and it must be non-stigmatising. People who are being offered a test should be able to ask questions about the tests if they have any. They must be aware of how they'll get their test results, and they should be given the option to decline, and that should be made easy for them. And if it's appropriate to the setting and the reason they're testing, they should be given or directed to health promotion information, so that if they are at ongoing risk, that they are able to access information that enables them to stay negative if their test result is negative. Next slide, please. So how do we normalise testing? Probably the most basic and simplest way in healthcare setting is a universal offer in a specific setting or condition. So, for example, someone attending a tuberculosis clinic, someone attending a primary care setting where they're registering for the first time. And so it is known by the staff and the people attending that we offer everybody a test in this setting. So there's no risk-based assessment, there's no need for risk assessment, and there's no feeling that the patient or an individual might feel that they're being targeted or somehow judged. We can also incorporate testing as part of routine care. So this is particularly relevant where we introduce indicator condition testing in hospitals or primary care, so that people know that they're having a number of investigations to manage their condition, and HIV is a part of that, or hepatitis B and C as well. And where possible, we employ an opt-out approach. So people know that we're doing these tests, they're made aware that the tests are being done, but they're given the opportunity to say they prefer not to have the test if that is their choice. Next slide, please. So giving two examples of opt-out testing. In antenatal clinics, this is the most effective and usual way of delivering HIV testing within antenatal services. So women at their checking in appointment are given information about the tests they're going to have, and this typically includes HIV, hepatitis B and syphilis, and they are advised of the importance and the relevance, and that they are given the opportunity to opt out. However, this is very rare. As Daniel said, the vast majority of people find this completely acceptable to be offered a test. And in the UK, we see this has been standard of care practice for many years now, and we have coverage of over 99% of women who are checking in for antenatal care in the UK are tested for all these infections. Next slide, please. Slightly more controversial and more difficult to implement is opt-out testing in emergency departments. And as Anastasia has indicated, this is included in the ECDC guidance. And if it's in an area of high HIV prevalence, if someone is having venesection already for investigations, it's recommended they have an HIV test. And if it's in very high areas of HIV prevalence, all attendees in ED apartments should be offered a test. And there are pilot projects have been going on in the UK for some time. Also know in Spain and Germany, this is being looked at as well. But even though we were doing it in the UK from April 22, all emergency departments were then were asked by the government to introduce bloodborne virus screening. So we had integrated testing in areas of extremely high HIV prevalence. People were made aware that they'd be offered a test via leaflets and posters. The posters had QR codes where they could access more information, and also translations in common languages were available. And the coverage does vary. People are still introducing some aspects of this, but it's up to 95% in some EDs. And this is quite incredible, because at the beginning, people were thinking there would be a lot of barriers around the time that might take out of, in what is very busy departments. Doctors and nurses are focusing on extremely unwell patients who come in for another reason. And this may be some barriers, but we've really found no barriers at all. Once the political will and the funding, most importantly, was there, this has really been a huge success. One of the other advantages of introducing it in emergency departments who didn't want to have to be involved in a lot of follow-up of patients, so that's assumed by the local sexual health clinics is we didn't want to be chasing up a lot of people with spontaneously resolved or previously treated hepatitis C PCR, hepatitis C antibody positive. So everybody gets reflex antigen testing. So we know who the people are to focus on obtaining results and ensuring they are transferred to care. In the first 12 months, so this is being done in London, Brighton and Manchester. We've made over 1,900 new diagnoses of people living with bloodborne viruses. The vast majority of those are transferred to care. And importantly, we've also identified a further 400 people who were known to be have one of these infections that are disengaged with care. And this has given an ideal opportunity to return those people to care and help them be retained in treatment and care. Next slide, please. The way that we deliver HIV testing as part of routine care and HIV indicator conditions is a key aspect of the strategy of increasing testing access and coverage in healthcare settings. So an indicator condition is where undiagnosed HIV prevalence in people presenting with the condition is at least 1 per 1,000 or 0.1%. And the evidence base for this, the largest evidence we have so far is the HIDE study, which across 12 indicator conditions found an HIV prevalence of 2.5%. So that's 25 times higher than the target for this strategy to be effective. In one indicator condition, infectious mononucleosis-like syndrome, it was extremely high at 6%. And this is a really important indicator condition because it is when this is very similar to HIV seroconversion. So people who are testing positive for HIV at this stage will be completely unaware of their infection because they've just become infected. They will be at their most infectious state because we know people's viral load is at the highest at seroconversion. And this is a prime opportunity in the most public health effective way of diagnosing people and transferring them to care. Next slide, please. Although I'm talking mainly about healthcare settings, I was also asked just to mention home samplings. And so this is important because a lot of healthcare services will be running and managing the home sampling in conjunction with some community organisations. So where this is overseen by healthcare services, we tend to manage the results and deliver the treatment, and it's usually for STIs and HIV infections for everybody. And then usually other infections, so bloodborne viruses, syphilis, will be dependent on the characteristics that are collected by usually online questionnaires. The access is typically online, and this has proved very effective in increasing uptake and coverage of those particularly at risk. So we find that a high proportion of MSM access these services, younger people, and particularly those living in more rural settings, which may find it harder to access physical services. Though I would say it's important to ensure that those experiencing digital poverty are not excluded by these mechanisms. And so we do need also to consider how we can provide alternative collection points for sample collection. So, for example, community services or community groups. Next slide. So thank you very much for that very quick overview of how we can look at the role healthcare settings can deliver to ensuring that we increase access and coverage.
Thank you to both of you, both Daniel and really, really insightful and both hopeful and encouraging presentations. And we also see that there's a lot of work to be done still. We have had some great questions. I'll start off with one for you, Anne. This goes like this. How can self-testing, it's from Susan Flores. How can self-testing be improved across Europe, and how linking it to care is managed when using self-testing?
That's a great question. So in my talk, obviously, I was talking about self-sampling, where the services are managing the results and contacting the patients and ensuring they're given all the information about transferring to care. The concern, I suppose, with self-testing, although it gives all the power to the patient and they get their immediate result, is how we ensure people are linked to care. So I think the main thing about that is providing adequate information with the test so people know exactly what they're testing for, how to read the result, and then how to access support and care. So I think if they receive a positive result, they need to know how to access healthcare support and transfer to care. They also need to be given information about community organisations that can support them in that moment as well. I think the main way we need to look at this is how the cost to people. So I know at the moment in a lot of places people have to pay for this themselves, and I think services and commissioners and policymakers need to look at how they can provide this for free to people who most need it. So based on their assessment of their epidemiological setting, they need to target it to particularly groups. So I know, for example, in the UK, we have a national program, but it's primarily only available to people from minority ethnic groups who are at high risk and MSM. And that's where the targeted promotion goes. I mean, people will not be refused to have it, but that's where we put all our effort into targeting. So we ensure that those people get access to that service.
Thank you, Anne. And then there's one question for you here, Daniel. It's from Albiona. She asks, is it possible to encourage people to get tested for hepatitis C during the routine blood screenings?
If it's possible, I mean, I advocate that it's always possible. It depends on what the approach is. I mean, Anna has a lot more experience in clinical contexts. I can speak a bit to the community part of it, and we have successfully offered testing to thousands of people through the process of pre-test counseling, where we talk to the person a bit about how their life is, what type of eventual risks the person may have gone through, and we offer testing. And generally, people are very keen on taking testing. I mean, Anne mentioned that as well for the clinical settings. I think ultimately, regardless of setting, it depends on how you approach the issue. If the person understands that there is a benefit in actually having more tests, I think it's perfectly fine, especially in a scenario where you are already getting a blood sample drawn. And so it's just another marker in the paper that's coming back.
Thank you so much. Now I have one last question. This goes out to all of you, and this is while going through and preparing for this event, this really struck me. So therefore, my question is: I understand that migrants, they don't have access to either HIV or hepatitis testing or treatment in roughly 50% of the EU countries. So can you, Daniel and Magda, speak to this from a community perspective? If you can start, Magda.
Yes, thank you for this question. In Poland, everybody who needs treatment gets treatment, and this is a very good option. And there is no people staying behind the treatment. So Poland is already prepared for that, because this is our law that everybody have access for treatment. But the problem is that those people have to know about the HIV status and do not afraid to disclosure their status, because one part are people who do not know about HIV, and other do not afraid to disclosure their status in new country that they came, because they are afraid of stigma, discrimination, and other problems. So this is also some kind of barriers to inform those people that do not be afraid, and there will not be a stigmatization in HIV clinic, because it doesn't happen. So this is something that we have to keep in mind. And also testing, it's important in those group, open STIs clinics. And also, in my opinion, self-testing would be the best option for migrants to have non-stigmatization testing option.
Thank you. And thoughts from you, Daniel, on this?
Yeah, so fortunately, Portugal is also one of the countries where, regardless of your administrative situation, you can access health services in general. However, in practice, this does not always work as it was supposed to. So there are a lot of administrative barriers for people who are not in a regular situation in the country to actually access the National Health Service. And I mean, this is something that we've been discussing at a European level for a long time, but unfortunately, it goes down to decisions by national policymakers, which may not see things exactly as we do. But it is a fact that in many countries, people who are not in a regular situation in the country cannot access life-saving care in many situations, not just for HIV, for many other diseases, infections, etc. And this goes back to the barriers that we were mentioning. There are a lot of policy level barriers that are not very difficult to solve with the right approach if we're looking at this from a human rights perspective, because there is a basic human right to health. And in practice, regardless of the country, I mean, now with the Ukrainian situation, with all of the migrant refugee crisis from Ukraine, the burden is much bigger on neighboring countries. And this also requires investment. But generally speaking, for the majority of countries, it does not represent an overburden, a financial burden to the national health budget. So
Thank you so much, Daniel. So I'd just like you, both Anna and Anastasia, to briefly, if you can sort of, from a public and health and clinical perspective, I mean, this makes no sense, that migrants don't have access. Could you elaborate brief on this, just because we're pressed for time?
I think from the point of view of clinical, particularly for HIV, especially now as we have because it's an undeniable public health argument that you're protecting, not even if you don't accept what Daniel says about human rights and the expenses to the country, it is just protecting your own population if you have everybody on treatment for HIV. So it's on every single argument, whichever way you look at it, it's really not shouldn't even call it an argument.
Okay, thank you. Anastasia?
Yeah, I fully agree with what all of the previous speakers have indicated, and would just say that in addition to the policy side, really looking at the barriers and educating populations about access to services, as Daniel mentioned briefly, is really, really key, because there are many countries where there's an official policy not to provide testing or treatment, but there are local NGOs who do so. But there's so much fear and so much stigma, and that has to be worked on that level, as well as we also work on policy level and sharing experiences across countries, that it's not a floodgate of cost. Actually, it's quite minimal in terms of the bigger overall healthcare costs that we have. Thanks.
Thank you so much to all of you. It's been a momentous event, and I'm really honored to have participated. It's time for us to close now. I want to express my heartfelt appreciation to each and every one of you. Your insights has really enlightened me, and I'm sure it has for all the audience. To Jens Lundgren, Anastasia Farris, Magdalena Ankerström-Badschak, Daniel Sumos, and Sullivan, thank you again. Your valuable perspectives and knowledge have illuminated the path forward, inspiring us to push the boundaries. And sorry about that, it was my timer. And your dedication in providing accessible and effective testing services will undoubtedly lead us to a brighter future, I'm sure. And I want to thank the European Centre for Disease Prevention and Control, ECDC, the European Testing Week organizers, and all the dedicated individuals working behind the scenes. Your commitment to promoting testing and awareness is commendable. Your collective efforts demonstrate the power of collaboration and reinforce the importance of working together to tackle public health challenges. And as we conclude, let us remember that testing for HIV, viral hepatitis, and STIs is not only a personal responsibility, but a collective one. By increasing access to testing, we can reduce the impact of these diseases on individuals and communities. And please, please, please continue the conversation beyond this event. Utilize the resources available, engage in organizations, and spread awareness about the importance of testing. Because together we can make a difference. Once again, on behalf of the entire team, thank you for joining us today. Stay informed, stay safe, and let us strive for a future where testing is accessible to all. Thank you again, and have a very nice afternoon.